to tell you, I think I've got one of the most exciting jobs because looking at what's happening to our healthcare world right now, there is no better place to be than in this world. I often tell folks that the best times of innovation occur when times are difficult. Or when you have a lot of money and you can do lots of different things. So in our case, times are not easy, but it's so exciting to see all the collaboration and all the great work that's happening. Earlier, one of my colleagues here in the audience asked me what we thought about physicians and what was happening with physicians in hospitals, and you see all this surge of hospitals buying practices, health plans buying hospitals, and all this happening. And my response to that is that all this is good because unless you do micro experiments and micro projects, you don't know what's going to work. And the important thing is to be measuring what you're doing to see if it's scalable or not. But just going back to what's happening to our healthcare system right now, obviously this isn't new news for anyone here in the audience. We have a healthcare crisis when it comes to affordability and cost. We are spending over $2.5 trillion on healthcare. Over 17% of our GDP goes into healthcare, and that's awesome if we're getting the value and we're getting the quality. But when you look at quality metrics like infant mortality and life expectancy, we are in the mid-30s when it comes to country rankings out of the 192 countries. So we're not getting the value for the dollar that we're spending. You look at our healthcare system, we have some of the most highly trained professionals. We have some of the most widespread technology, research, innovation, cutting edge, development. We have great care that we deliver to individuals, to patients. We take care of diseases. We cure diseases. We're turning things around with genetics and genomic sciences. But when you look at the other side of what's happening to our healthcare system, our care is fragmented. We have problems with uninsured and underinsured. Not everyone, the world's superpower does not have universal access to healthcare. We have the practitioners and providers all disenchanted by our system. They're not happy. I had a potential medical student come up to me earlier asking me if healthcare and being a physician was something that she should be looking at seriously versus business. So there is that feeling of dissatisfaction within our profession. And there is a systemic issue with quality. So we're doing a great job treating disease, but we're not taking care of our sick healthcare system. So that's sort of the dichotomy of where we are. And that's sort of the premise of what's happened from an overall national policy perspective on healthcare reform. And so in 2010, when President Obama signed the Patient Protection and Affordable Care Act, it was a monumental piece of legislation. It was something that was needed in terms of improving healthcare. It was on the premise of two main things. The first thing being that we need to make sure that we have universal access. There should be no American who has to die because the American cannot get access to health care. There should be nobody that has to mortgage the house and a life of savings in order to get health care. And the second premise was the affordability of healthcare. Is there any way we can bend the cost curve? So those were sort of the two guiding principles of the Affordable Care Act. And obviously a lot happened through that over the last couple of years until June 28th, when the Supreme Court came out with the ruling on the constitutionality of the key component of the Affordable Care Act, which was the individual mandate. That was the main piece of what the entire argument was around really the constitutionality of this law. In other words, can we force people to buy insurance? That was really what it was. And the Supreme Court, again, the historic ruling 5-4, with the Chief Justice taking the side of the liberals on the court, actually upheld it based on the fact that this was constitutional under the tax clause. And again, when I sit back and we talk about any insurance model, there is no insurance model that works if the only people buying insurance are the sick people. right? I mean, how do you, that business model would never work. So the whole idea is, how do we make sure that everybody has insurance, and it's the healthy people who in some way are subsidizing the care of the sickest people. Now, this is this element of the principle of how things work is very common to both sides of the aisle. The Republicans believe in it too, and so do the Democrats. The only difference in terms of what they believe in it is, how do we get to that end point? Based on, obviously, our current law of the land, it's going to be as a result of taxes that will be imposed, taxes or penalties or fines, whatever you want to call it, on individuals who do not buy insurance. Based on some of the things that the Republicans are coming out with, they're actually putting forth sort of the idea that we can do it, but through other mechanisms where you have health savings accounts, you have high deductible plans, you have high value, low cost options for individuals and small businesses to get similar kinds of coverage, but then at the same time have incentives where the pre-existing conditions are eliminated if you have continuous insurance. So that's really some of the proposals that are coming up by the Republicans, who are wanting to actually repeal and replace the Affordable Care Act. But whatever happens in November, whatever happens in terms of the elections, at this point it is the law of the land. And I think what we need to be doing is moving forward with looking at how we're going to be working to come up with solutions so that we bring more accountability and more affordability into our healthcare system. How do we bring it in a way that people are talking to one another? We're not repeating tests. We're looking at quality. We're not rewarding people for doing things that are wasted, unnecessarily, or damaging to our patients. Right now, if a patient gets admitted to the hospital and the patient has a fall while in the hospital bed, develops a hip fracture, has to go to the operating room, gets hip surgery, develops a heart attack, has to have bypass surgery of the heart, needs to go into a nursing home, all these things are paid for because we as a system in the hospital didn't take care of the patient right? We didn't prevent the fall. However, what we need to be doing is paying based on outcomes. What was the care that we provided? What was in terms of metrics, in terms of solutions? How did our patients do? And based on that, reward providers within our system. So those are some of the things that are moving and are actually happening very actively as we're talking. The one provision of the Affordable Care Act is something called the Accountable Care Organization. That's something that I'm involved with, but it's really it's a 7-page piece of the over 2,000 pages of legislation that talks about having physicians and hospitals, with or without hospitals, come together and be accountable to the care. And if the projected cost for a certain population is higher than what the actual costs are, withholding the quality, as long as you're meeting those quality measures, then the difference between that projected cost and the actual cost will be actually shared between the providers and CMS and Medicare. So this is an example of the kinds of pilots and demonstrations that are going on. So I think it's going to be a very, very exciting time. What applies to you here in the audience is something called the employer mandate. So what happens today? If we have a patient, or if we have a New Jerseyan who doesn't have insurance, right, today, well, if the patient gets sick, he ends up in the emergency room. The emergency room takes care of the patient, and under the EMTALA law, you cannot deny the patient care. The patient gets admitted, and now the hospital has to pay for this patient's care that who doesn't have insurance. Under the new law, what's going to happen is, based on the income level, the patient will be eligible and will qualify for various provisions within that so that the patient has coverage. If the federal poverty level, the income level, is less than 133%, then as a result of Medicaid expansion, and again, that was another piece of the Supreme Court ruling that came about where states did not have to participate in the Medicaid expansion provision. But in the state of New Jersey, our Medicaid benefits are so rich that it really doesn't make a difference to us. But under Medicaid expansion, the patient could get health care through Medicaid. The patient could, if again is above 133% of federal poverty level, can go to the health insurance exchanges, and between 133% and 400% of federal poverty level can buy insurance with subsidies based on income levels. So you're going to, you will have to buy it. Otherwise, you're going to face penalties as a result of the individual mandate. If you are if you're employed and your employer has 50 or more employees, then there is an employer mandate that comes into play where the employer has to provide for health insurance or else will face penalties. So those are the different ways by which this individual will get insurance. But there are flaws in the system, and the flaws are that the penalties are not strong enough to incentivize people from getting insurance. So as an individual, the maximum penalty is $695 or 2.5% of your adjusted gross income. Now, as if I were a 25 or 30-year-old healthy woman, I would say it's okay to give the penalty. If I have a catastrophic event, if I need urgent health care, then because the pre-existing condition piece no longer exists, I can buy insurance tomorrow as soon as I get diagnosed with, let's say, cancer, and no one will deny me insurance. So here, the penalties aren't strong. I didn't have to buy insurance, and the moment that I need insurance, because the pre-X conditions don't exist, I can easily go get insurance. So that's one of the scenarios that people are saying, or the policy folks are saying, will have an impact. Similarly, the employers may say, well, it's better to pay the penalty, not provide health care benefits, and have them go through the health insurance exchanges that every state will set up, and we're fine with that. But I do really think that at a time like this, what's actually going to happen, especially with the large employer and the small employer group market, is that they're going to start looking at various ways of still providing health care benefits, but in a more cost and affordable manner, with maybe a little bit more cost shifting. The one model that seems to have a lot of discussion around it is a combination package where you have a health savings account and you give a certain amount of money to the employees and say this is for your preventative care, and then at the back end you have a high deductible catastrophic insurance coverage plan. So that hybrid model is something that I've seen a lot of the employer community start talking about, so that it's not as though they would not give benefits to healthcare benefits to their employees, but at the same time maximize on what the opportunity is. So there are flaws, but at the end of the day, I still feel that we have to move. We can't have status quo. We still have something, and the opportunity is to look at ways that we can improve our healthcare system. We have issues with an aging population. 13% of Americans right now are 65 and older. By 2030, that'll go to about 20%. We have about 10 million Americans of the age 80 and older. By 2030, we're going to have 20 million Americans. And with that, we increase our cost in terms of long-term care services. For about 11 million Americans, we spend $200 billion on long-term care services, half of which is paid by Medicaid. So these are issues that we're going to have to grapple with in terms of the cost of care. An average adult, for instance, we spend about $3,000 a year on health care costs. We spend 3 times as much once they get to the age of 65. Every day we have about 10,000 people turning 65. We have baby boomers retiring, and our healthcare system is becoming more and more burdened with chronic illness. 7 out of 10 Americans die of chronic illness, and so managing that chronic illness where we have people talking, providers talking to one another and coordinating care is going to be key. How many of you in the audience, go for a procedure or go to a hospital for whatever reason and have to repeat the same information again and again and again? Health information technology, adoption of EMR is going to be critical. It's going to be the nexus that brings us all together. It's still, it's not something that's going to be easy to adopt. I talk to many, many physicians every single day, and there is a big learning curve, and there's a time where productivity goes down in physicians' offices, but that's going to be a must-have versus a need-to-have. So those are going to be some of the things that are going to be critical. The other piece that's very important for us in New Jersey is that we are the 3rd most diverse state. 1/3 of our population speaks a language other than English at home. So with that, with the diversity of our population comes the diversity of chronic disease, prevalence of disease, and outcomes of disease. In the African Americans, we have a higher incidence of asthma. In the Hispanic population, we have a higher incidence of diabetes. In the Asian population, we have a higher incidence of heart disease and certain kinds of cancer. So all these things have to come together. We have to make sure that our healthcare workforce understands what this diversity means and how do we close the gap in terms of disparities in healthcare. And for one, I always talk about not being culturally competent, but culturally sensitive, knowing what those barriers are when you're dealing with different kinds of populations. Those are going to be key components as we look at that. The physician shortage issue is going to be an important thing that we're going to have to address. Today we have a shortage of physicians, about 1,000 physicians short here in New Jersey. It's going to triple in the next 10 years, and this is without taking into account the Medicaid expansion, which means with the Medicaid expansion, we're anticipating across the country an additional 20 million people who are going to get insurance. So with all that happening, we're going to have to deal with the workforce issue. So we're going to have to work with different ways of connecting with our patients. It's not going to be your traditional visits. It may be e-visits. It may be telemedicine. It may be virtual visits. It may be expanding our workforce where we have nurses, nurse practitioners, other kinds of healthcare professionals playing a different role. All these things will be happening as we're talking about innovation. When I went to medical school, I was always taught about medicine being both the science as well as the art of what we do. So it's the art and science of medicine. When I spoke to the student earlier today, it's not just the science and art of medicine, but it's the business of medicine. We're going to have to start looking at how we're going to be successful. So for those folks who are interested in doing medicine and in the audience here from high school, I think this is a perfect class because you will have to do both business and medicine together. It's not just going to be one piece. In the end, I feel that the opportunity is tremendous. There are lots of moving parts, but it's taking one piece at a time, looking at where you're going to go, and working together collaboratively, looking at what's working and seeing if we can scale it. And I'm very optimistic that we have the right people who are engaged at this point, the right policy folks, the right healthcare professionals, the right academicians, the right legislators, all of them wanting to do the same thing, which is to make our healthcare system affordable, high quality, and access to all. No matter whether you're, which side of the aisle you're from, this is sort of where everybody wants to be. How you get there is another discussion, but this is going to be actually very, very important.